I'm Dr. Jeremy Rogers, a consultant terminology specialist at NHS England, and this ePoster is about how clinicians use SNOMED CT. The UK's primary care physicians have been among the global leaders in coded electronic patient records for 3 decades. Last year they added more than 5.8 billion new coded items to the nation's GP-held records, and this lake of data presents an opportunity to try and answer some important questions, including what codes do clinicians use? How long do new codes take to become adopted? And are clinical coding behaviours consistent? Once a year, NHS England gets a comprehensive audit of what codes have been added to the nation's GP-held electronic patient records. Each GP system supplier submits a table listing all unique codes used at least once in the last year to make a new coded EPR item within their deployed estate, together with the number of times each code was actually used. They also report the number of practices and patients in their system at the end of the relevant year, and we now have such annual returns for 12 successive years, and an aggregated version of the raw data is also publicly available. What might this data tell us? SNOMED currently provides around 230,000 codes for recording the core clinical ideas of diseases, symptoms, their treatments and investigations. These codes are associated with 380,000 different synonyms, each between 1 and 255 characters in length. The grey histogram shows the distribution of those synonyms by their length. Most are clustered around a peak at 30 characters long, but about a fifth are 50 characters or longer. Those longer terms include clinically detailed diagnoses like short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing syndrome, or procedures like referral to diabetes education and self-management for ongoing and newly diagnosed diabetes structured program. The red histogram shows the distribution of the 9 billion new coded electronic patient record items added across UK general practice in the 24 months to July 2022, by the number of characters in the preferred term of the SNOMED code selected. What's used is shifted a little to the left by comparison with what's available. Only 15% of GP data was recorded using codes with a preferred term of 50 characters or longer. The blue histogram is derived from similar code usage data obtained but from a small sample of just 2 hospital trusts, where 5.5 million inpatient coded diagnoses and procedures had been recorded over several years. But this limited data suggests hospitalists favour shorter terms slightly more than their generalist colleagues in the community. Only 2% of all their data used a code whose preferred term was 50 characters or longer. SNOMED's code set continues to grow, mostly on request, by about 10,000 codes annually. Of the 230,000 clinically useful SNOMED codes mentioned earlier, 30% were created only in the last decade and 9% in the last 3 years alone. Code usage data can tell us whether these codes are in fact used. Each line on this graph corresponds to all the new SNOMED codes created in one of the years since 2011, and it reports what percentage of those new codes had failed to achieve a usage level greater than 1 new electronic patient record item per million patient years of care during each of the years following its release. Between 5 and 20% of all new codes will exceed this minimal level of use within just their first year after release, whilst another 5% or so will take up to a decade to catch on. But more than 70% of all new codes are consistently fated to be never used, at least not in the generalist setting of UK general practice, one of the largest deployments of SNOMED in the world. Code usage data can also reveal whether clinician coding behaviours are changing. The annually reported usage for each SNOMED code forms a time series with 12 data points, one for each year. Using linear and quadratic regression, these time series can be categorised according to their apparent mathematical time trend: increasing, decreasing, concave, convex or broadly flat. All time series sharing the same trend were then rescaled so that they shared the same arithmetic mean value of 1,000. The next slide shows the result of plotting together on the same chart and scale examples of real rescaled data series that were categorised to the same trends. Half the codes were categorised to a rising trend for the 8 years before the pandemic, 16% to a falling trend, and just 5% was stable over time. Other clear trends include the convex cup and concave cap patterns. Let's now take the exact same series that are displaying now on the 5 charts and extend them through the 4 years of the pandemic. It's clear from the graphs that many trends so clearly established during the 8 years to 2019 were suddenly unravelled by the pandemic, and most have not yet returned to the old trend since. This change in coding behaviours is both sudden and profound. Whether it reflects equally sudden, lasting, profound changes in underlying clinical practice is not known. In conclusion, therefore, the available code usage data from UK primary care suggests that clinicians avoid clinically detailed diagnostic and procedure codes in favour of shorter and usually less precise codings. Most new codes added and never used, especially those that need long terms. Coding behaviours of clinicians are constantly changing, with many codes falling either in or out of favour. The pandemic caused a sudden change in coding behaviours of uncertain significance. Similar code usage data from other care settings would be extremely valuable, but is hard to obtain.